Hi, my name is Sydney. I will be presenting my capstone project. I will start off just by saying a little bit about myself. So I have been a registered nurse since 2024. It's kind of crazy. It's already been almost 2 years since I've been doing this. When I started as a nurse, I really didn't know exactly what I wanted to do. I had a love for psychiatry, which is usually not very common, but I just felt like this gravitational pull towards it whenever we had clinical. When I first started, I didn't really know exactly, but I knew that I did like psych. I just didn't really know what it would be like incorporated into practice and what I would be doing as a nurse and what my job responsibilities would be. I did go to clinical. I think it was like 2022, which is even further away. But when I went there, I remember loving it. I think I was out of like 10 students, I was the only person that enjoyed it. And everybody else thought I was crazy because, it's just not a very common specialty for people to enjoy, which is why we need more nurses in the field. So just to give a little bit of background about who I am, I do work at Kentucky Children's. I don't know if I said that already, but what we've been struggling with has been very difficult since COVID, which I will cover a little bit in this. The rates of mental health patients being admitted into the ER has like skyrocketed. One of the providers had told me a little bit about it, and since we've been dealing with all these patients that we're getting, it just doesn't feel like it's really being compared to into translation with how many staff we have. Usually, just to preface, we only have about 2 nurses on the floor. We can get as far up to 14 patients until we get a 3rd nurse. That is very difficult, and I'll kind of dive a little bit more into that. But really, the point of today and why I'm doing this presentation and something that I've actually been working on with upper leadership is to get an acuity-based tool that we can use to score a patient in order to help our ratio a little bit better. So I'll go ahead and get started. So again, to preface, this is about an acuity-based staffing model for pediatric inpatient psychiatry. Okay, so the introduction, which I've kind of already talked about a little bit. So we are seeing much more high acuity of patient that we're seeing. In the ED is usually where they start out. What I mean by high acuity, which a lot of people don't know, and I'm so sorry if you can't see this, I'm trying to turn it and record it at the same time, but acuity basically means high risk or high violence. That's a way that I usually like to say it because it's just like an easier way to understand it, but that's why I call it acuity-based staffing models, because we want a model to basically help us when we do have these patients that are very high risk. If we have a bunch of high acuity patients, that means we're having to monitor more frequently, we're having to redirect more frequently, and we need more people if we're going to have to be doing all that stuff, plus all the things that we already have to do on a day-to-day basis as a nurse. We need more people to help us with the patients that are harder to deal with. So like I had said previously, we are usually a 1-6, 1-7 ratio. Those ratios are medical surgical staffing ratios, or fixed traditional ratios as they call it. Those just don't reflect, those models at least just don't reflect what we actually need on the units. So the purpose and objectives, I really hope you can see this, I'm sorry. So the purpose is to find out if using an acuity-based model would help improve nurse and patient safety and keep more staff long-term. That is something we're dealing with a lot right now, is because we just had a model, a not very good one, come out, and a lot of people started leaving because it was like we were advocating that we really needed more staff. And then we waited a month to figure out what our model was. And then all I'll say is it was not good. And it didn't seem like anybody was listening to us in that sense. So our objectives are to review the problem and PICO question, summarize literature themes, present the recommended staffing model, so the acuity tool, which I will share, discuss fit, feasibility, and action plan. And then we will identify the expected patient and nurse outcomes. Sorry, it's hard to read at this angle, but So the PICO question, kind of what we already talked about in pediatric inpatient psych units, does this tool actually help? Is it going to be better than what we have right now? I think yes, but maybe I'm a little biased. I do think that it will help in the long run. So some of the things that we're going to be talking about, that is a summary of kind of what my whole paper was about, is the rising inpatient acuity or patient violence or high-risk patients, burnout related to the inadequate staffing, which we're having a lot happen right now, myself included, staffing levels linked to safety outcomes, and the need for staffing based on behavioral risk rather than just a number of patients on the unit. So rising patient acuity. I have a bunch of statistics on here. Basically, one of my favorite ones is talking about how, so the suspected suicide attempt statistic, according to the CDC, since in comparison from 2019 to 2021, which we're not even talking about right now, which has to be more, but the amount of suicide attempts was 50.6% increase. That is a lot. That's just like one statistic that I have. There's just not a lot of statistics on it, which I hope here soon we'll get more, because I mean, since 2021, it's even worse. So, that is a really good one. But speaking of that increase right there, is saying that we have a lot of patients that are being admitted. That's just for suicidal risk or suicidal ideation or had a suicide attempt. That's not even including all the other diagnoses that we see. Basically what I said was that clearly we're going to have an increased need for all these admissions, and if we have a bunch of patients but we still have really low staffing ratios, how are we going to get this a little bit more balanced, is mainly what I'm saying there. So burnout related to inadequate staffing. A lot of the staff right now is very burnt out. It is very, very overwhelming being on these kind of units and having these kind of safety events, and then advocating and voicing everything that we do and nothing changing. That is one of the big factors as to why a lot of the people are being burnt out, and I can almost guarantee that's why most of the in psych is burnt out. This one is just a little bit about it's just more evidence that I pulled from my paper, but there has been staffing issues for a long time. I did find an article all the way from 2004. That was when my brother was born, so that's been a pretty long time. But basically it was this article that I found was saying that like keeping staff in this field specifically is very, very hard to do. We have also put, I had put on here too, that nurses working in behavioral health have the highest turnover rates, which is also something that I could see happening. And then recruitment and retention, like I had said before, is very hard. Somebody said that it was at a crisis point. So it still seems though, nothing's changed. I mean, I've had multiple staff members quit and leave, and I've only been there for almost 2 years. So it is a hard specialty to stay on. And I think that hospitals need to really try to keep the staff that they do have, because not very many people want to be in psych, and keeping the staff that actually want to be there and actually want to make a difference are the ones that are important. And I feel like one of the big things that we deal with is a lot of people are like, oh, well, like all hospitals, everyone says that you're replaceable. And that might be true. Maybe I'm just speaking out of nothing right now, but I would argue that that's false, only because specific maybe to psych, but psych is one of those fields where you're not going to have a massive amount of people trying to apply for working there. It's such a different specialty, and it's very specific, and I feel like not a lot of people would want to do that, and so maybe keep the people that actually do enjoy it and want to work there and be there and be safe. That's all I'm saying. Staffing levels and safety outcomes. So I had put, again, more of my quotations that I had found. Basically, a lot of the research I found that if we had more staff, we would have better outcomes, less restrictive measures being taken. One thing I do notice, just being on the unit, if we do have very high census, low staffing, I I do feel like, and this probably isn't right, but I do feel like we maybe have to use seclusion or restraints or have to give IMs a little bit quicker because we don't have the capability of leaning on staff support because we only have each other. Most of the times when I have an event, the other nurse is working with me and there's only 2 of us, and we still have potentially like 10 more kids that we're dealing with, in which multiple out of those 10 can be a problem. It's not good. I've had a code go on. 2 of my 6 patients went off at the exact same time. I had bed restraints on one hallway going that I was doing, and then my other patient was going off on the other end, having to be put in chair restraints. And that was a very, very stressful situation because both the nurses were held up and we had to rely on the mental health associates to make sure that all the other patients were safe. So this is basically saying that, like, I liked this one. It says that children with common conditions treated in hospitals in which nurses care for fewer patients each are significantly less likely to experience readmission. On inpatient psych units, we have a significant amount of readmissions. Most patients that I have, at least more than half of them, I've already had before. My patients call me by name, and I hadn't even seen them in months. So, or I had seen them in weeks or days. Like, it's usually our stay is only 3 to 5 days. So the amount of times that we get readmissions, I mean, I've had a kid as many as close to 10 times that I've had just the one singular patient on repetition. So it happens a lot. Also, I liked this quote too. Sorry, I'm going to try to be a little quicker because I know I'm running out of time. But an Acuity tool, this is one of the quotes. It says, an Acuity tool can help standardize practice, determine fair patient assignments among staff, increase nurse satisfaction, and promote best practices for patient safety. That is a very good quote, and that is why I want it to work and I want it to happen. I think it would be so much better for everybody. I'm going to play this really quick. Actually, I'll just skip it, but I'll leave it just so that you can see it. I have a video on what happened at this unit in Louisville. This happened, I believe it was last year, but it was like end of last year. Basically, it was a pediatric psych inpatient unit. They had a full unit, only I think 2 staff members, and the children, the juveniles in the unit, rioted against the 2 nurses that were there. I don't know exactly if they got injured or not. I think that they were able to get to the medication room to keep themselves safe, and they were able to lock themselves in there. One of the patients that was in that riot was on my unit. We didn't even find out until after the patient had already left, but this event is seriously, like, if you watch the video, I put it on here. I would highly recommend watching it. It'll give you some goosebumps. I was watching it just to put it in here and I got goosebumps just because this is my reality. I deal with this all the time where I'm feeling like I'm not safe, or I just don't feel safe. I know my coworkers feel the exact same way. And I know if I don't feel safe, then the patients probably don't. And then on top of that, we do have a lot of kids that have a little bit of manipulation tactics. They're not stupid. None of my patients are stupid. They do know, and they can tell if there's less of us and more of them. And all it takes is one kid to completely flip around our entire unit, which is what happened in this. So yeah, just watch that. It kind of just highlights everything I'm saying, as, you know, this is very important and this is real. This does happen, and thankfully the nurses were safe and everything worked out, but it could also not. So, this was in Louisville, Kentucky at OLOP. So I would highly recommend watching. This is the video. Basically, it's the 911 call from the nurses. They released the 911 call. And essentially what they say in it is, you know, we don't feel safe. This is not going well. Please help. So, recommendations from literature. This is what my literature supported. This was just saying that we should move away from fixed models, and we should work towards something that will actually help and actually account for patient acuity. So an Acuity staffing tool, which I'll explain, would include a DASA score. It's a score that basically ranks how violent a patient could become. I believe the highest is an 11. Most of our kids are in the 8, 9, 10 range. So active or passive suicidal ideation. Active means they are going to do something, they won't tell you, and they won't keep themselves safe. Passive is the opposite of that. So they would tell me probably won't do something, but they just have the thoughts of it. ADLs, if they can do their ADLs, activities of daily living. History of aggression, elopement risk, meaning would they try to escape, or are they going to be suspicious around doors? And then if they've had restraint or seclusion events in the past 12 hours. That's how we would score them. So the tool that I'm talking about, so it would have 4 categories. The main 4 categories, all those things I listed would be kind of included in that. This is just, it would fall into one of these categories. So DASA score, the dynamic appraisal of situational aggression, so violence score basically. Suicidal self-harm screening, function and ADLs, behavioral history, red flags. Those 4 categories would be scored from 0 to 3. The range would be 0 to 12. Basically what this would do was if a patient is a very high acuity patient and they're in the 12, like 10 to 12 range, that would mean that one nurse that's taking that patient would have a lot less patients or none at all, and it'd be a 1-to-1 nurse to patient. Scoring would be reevaluated every shift. And then this would just help us in the sense of having multiple high-risk patients at one time, which has happened and continues to happen. So fit, feasibility, and appropriateness. So like I said, our current model, it's not great, 1 to 6, 1 to 7. There is no tool in place right now, which is not good, no fun. We need one. And leadership support is necessary if we want to make this work. That is something we're trying to deal with right now. So action plan, we would present the evidence and put a mock tool, or we would just show them the mock tool to leadership, which we have done. We would pilot the tool on the unit. We would collect data on restraint use, staff injury, and safety events. 4th, we would improve the tool based on the findings, whatever we got from the data. If all those things improved, then we're good to go. And then 5th, provide staff education and training on how to use the tool and how to score the patients. Needed resources. We need leadership approval, which we've kind of gotten. Hopefully that will actually go into play. Staff education time, which I think we'll be able to figure out. System for tracking safety and staffing data, which we could figure out as well. And then ongoing evaluation. So we just to see how our progress is and if it actually is working and helping us. Barriers, budget limitations, administrative approval, data collection, and ongoing leadership support. We do need somebody to be our advocate and help us because our unit is one of the most looked down on units, and we definitely need some people on our side for this. UK has a lot of budget limitations. I want to speak lightly on that one, but hopefully that isn't a problem because it shouldn't be. Then expected outcomes. So hopefully with this tool, we would have some reduced restraints, fewer staff injuries, which would be amazing because I don't like getting hit, kicked, but spit, punched, and all the above. Improved workload balance, so we don't feel so stressed all the time. Improved nurse satisfaction. I would love to feel a little bit happier at work. I do love my job, but I just wish that it was a little bit safer and I felt safer. Safer patient environment. When we have all these codes and everything, we do have patients around, so it is unsafe for them when we're having to deal with all these things and we don't have enough of us up there. Implications for practice. The staffing should reflect real-time acuity. That is what we're trying to get. Pediatric behavioral health has limited research and a high stigma, and supporting staff in this specialty improves retention and patient safety, which I agree. Conclusion: when staffing does not match behavioral risk, nurses are stretched very thin. Evidence supports moving toward acuity-based staffing, and a structured tool has the potential to really improve staffing and safety. And then all my references, and we are done. I got it right before But thank you so much for listening. I hope you do watch that video because it really is good and it will really show you kind of what I deal with on a day-to-day basis. And hopefully this mock tool will come out and I will actually get to say that I helped create that. I did kind of help, but I gave him a nudge just because I was so fed up with the things that have been going on. But I do hope that in the future, some kind of tool like this comes out for Ped Psych and that there's just a little bit more research and evidence and everything to back this up for the future, because there's just not that much. And that's mainly because it's stigmatized and not very many people view it as important as physical health. And it really, truly is just as important, maybe more. Because if we don't got this, we don't have anything. So thank you so much. I'll keep rambling and I don't want to get points taken off for talking too much because I do that. But thank you so much for listening. I hope you have a wonderful night and